Hi, my name is Anna Franklin, and today I am presenting a Healthcare Leadership Symposium for Business Communications for Healthcare Managers at West Texas A&M University. The title of my article is What Determines the Surgical Patient Experience? Exploring the patient, clinical staff, and administration perspectives by authors Dr. Olena Mazarenko, Dina Zemke, William Hara, Noel LaForge, Stowe Shoemaker, and Nir Menachemi. I obtained this article from the Journal of Healthcare Management, and it's related to healthcare communications because the patient experience is defined as the sum of all interactions that influence a patient perception across the continuum of care, including provider to patient communication. In October of 2012, Medicare began rewarding hospitals that provide high quality care for their patients through the Hospital Value-Based Purchasing Program. Patient experience is one of the measures tied to Medicare reimbursements, and given this new system of rewarding hospitals for increased patient satisfaction, a research team conducted a study at one acute care for-profit hospital in a western state, which examined the determinants of the surgical patient experience from the perspective of the multiple healthcare team members, including the surgical patients, family members, physicians, nurses, and hospital administrators. 3 of the research authors conducted 12 focus group discussions in July and August of 2013. The sample size included 15 patients, friends, and family members, 17 physicians, 6 nurses, 6 physician schedulers, and 29 hospital administrators. Each focus group was led by a moderator. It lasted around 75 minutes and asked a series of questions about their surgical experience within the previous 6 months. Questions focused on patient satisfaction, patient experience, processes that the patient encountered, as well as their post-surgical concerns. 3 individuals independently coded each fragment as they related to each of the 18 themes that emerged from the responses. 3 themes from the study included interdisciplinary relationships, technical infrastructure, and staffing. Issues surrounding interdisciplinary relationships involved physicians where patients were receiving conflicting instructions from their physician and the hospitalist assigned to their post-surgical care. This made it difficult for the patient to know who to trust and what information to trust. Hospital to physician communication was also another opportunity, as the hospital staff often did not recognize the physicians by sight, sometimes mistaking them for physicians. And the chain of command structures created unnecessary complexity in making quick decisions and providing fast responses to patients and family members. Issues surrounding technical infrastructure involve the patient charting process, as the process of charting patient notes oftentimes pulled providers away from the bedside, preventing them from adequately communicating with patients and providing direct patient care. The third category was staffing, and this is where an additional opportunity existed, especially during the evening, night, and weekend shifts, as the administrative responsibilities increased during those times, resulting in decreased patient care. Interestingly enough, many patients were unaware of the hospitalist's role in providing care during their post-surgical stay. Patients stated that the hospitalist did not introduce themselves, they did not familiarize themselves with the patient's chart, they wrote prescriptions and care plans that contradicted the patient's physicians, leading to confusion, fear, and probably a lot of mistrust in the process and feeling comfortable upon discharging from the hospital. This was a very in-depth research project that relied heavily on qualitative feedback from a variety of impacted stakeholders surrounding the surgical process. It was well written and organized, and it would be interesting to perform a post-study once communication and operational improvements were implemented and hardwired within the culture of the hospital. 4 questions I ask of you based on this article in our learnings are: 1. Should Medicare reimbursements be the driving force for enhancing surgical patient experience? 2. What is the appropriate way to incorporate interdisciplinary relationships, technical infrastructure, and staffing into the HCAP survey? 3. What improvements can hospitals incorporate to improve the patient charting process? How will these improvements improve direct patient care and nurse-to-patient communication? 4. What checkpoints can providers implement in their processes to guarantee communication is occurring as it should so patients have a positive experience? In conclusion, the author's approach resulted in the identification of several improvement opportunities which can be applied across the country and across multiple different hospitals and units. I enjoyed the author's approach as they obtained feedback from all of the stakeholders involved in the surgical process and applied a quantitative method to qualitative feedback, which is rather difficult in certain situations. This article forced me to take a step back and analyze communication from a patient experience and a reimbursement perspective. It also reminded me once again that communication is vital to all aspects of healthcare. Thank you so much for your time and have a wonderful day.